this computer. All right, here we go. And I have an activity that I printed out on the printers. It's just in the office, so I'll go grab it um, after we get through this here. So there's the objectives for this unit. You could read through those on your own. So we're talking about this demographic of elderly. Generally, we're talking about people who are 65 and older for this demographic. And there's a higher rate in this is a kind of a big topic because not only are there changes in the oral cavity that we want to think about that elderly patients have, but they have all sorts of barriers, sometimes access, getting places, financial barriers, comorbidities. There can, like you can see here, there's lots of common conditions in elderly individuals, from heart, cancer, diabetes, autoimmune. I mean, there's just so many things. But then on top of that, there are some changes that just happen with age. But a lot of the changes that are negative happen because of diseases, not just because people age. So it's sort of a misunderstanding that as people age, things just deteriorate in their mouth. If they're healthy, there should be actually minimal changes, although there are some actual physiological changes that do occur. In general, a lot of the bad stuff is due to a lot of these comorbidities and these other chronic conditions. So in 2012, 60% of older adults managed 2 or more chronic conditions. So polypharmacy, lots of medications, usually at least more than 3 medications on board, and they all can affect the oral cavity, either a little or a lot, so we just have to be aware of all these things. And then also things like vision and hearing problems. I really was kicking myself last night because every year I've wanted to do this exercise where everyone, like half the class, goes and grabs their safety glasses from the clinic. But I'm like, well, we can't all run into the clinic this morning because the freshmen or the juniors are in there. And then if you take like a thin smear of Vaseline and you put it on your glasses, and then you have so you do like a mock-up and you have your patient fill out a handwritten health history with their Vaseline glasses on. And then the other activity is putting like cotton in your ears. And so it's like mimicking like how it is to not be able to see very clearly or not be able to hear. And it's really fun activities. And every year I'm like, I'm going to do that next year. And then I just don't prepare enough. So anyways, one of these years I'll do it. I know, didn't that sound like fun? So, but those are things that we have to be aware of and think about how our patients, and a lot of times they might not hear very well, but they don't want to admit it, or they don't, they might hide it. So we just have to be really aware about some of those limitations that they may have. Okay, so for healthcare for older adults, there's 2 terms to differentiate. Geriatrics is the actual branch of medicine. So if somebody is practicing in geriatrics, they are practicing medicine concerned with the illness of old age and their treatment. And then gerontology is the study of older individuals and sort of everything that comes along, scientific study of factors affecting the normal aging process and effects of aging. And the terms are not interchangeable. So gerontology and geriatrics are 2 different fields of work. One is the branch of medicine, the other is the scientific study. Determining health status. So we want to think of a couple things when we think about the health status of our elderly patients. You want to consider chronological age versus functional age. So you can have a young old person or an old young person, and you know what I mean by that? Like somebody could be 95 and spry. We all know them. I mean, I have had the most amazing patients in their upper 90s, driving, living independently. Did I tell you guys? I think I tell this every year because I still remember her. When I lived in Arizona, I had the most beautiful, youthful 98-year-old patient. I mean, I would never have put her over 75 ever. And I just thought she was like, it was just creepy almost. I'm like, you're 98? You're 98? I mean, and I wasn't trying to be insulting, but she was so beautiful and youthful. And it happens, there's people who just, their genes are right. They live more like stress-free lives. I'm convinced they don't worry very much. I'm convinced that's part of it. Because I used to ask, in Arizona, I had lots of elderly patients, and I'd always ask, what's your secret? And they always know, nobody worries. So I'm dying young, but that's okay. And you guys will stop worrying once you're at a hygiene school, so you'll be fine. So we want to think about their chronological age versus functional age. So they may be very high functioning. And so you take those things into consideration, or that you could have someone come in that's 55, that's very, very limited because of some chronic condition. And so even though they're not elderly, they may be in that bracket just because of chronic conditions that they have. And then activities of daily living, I put these in just kind of abbreviated in the notes. So when we think of activities of daily living, we think of things like, are they able to do some of those basic things like bathing, using the bathroom independently, transferring from their bed to the chair? Can they move around and do some of these kind of daily life activities that any functioning person, will do for themselves? And then when we think of instrumental activities of daily living, we're thinking of things a little bit less, I don't want to say important, but things like managing their money or making their own foods. They may be able to shower and toilet, but maybe somebody comes and cooks for them or does their bills. So there's like different levels of functionality. And then we want to also be aware of the terms acute and chronic, and in relation to the condition. So acute conditions were more prevalent like before modern medicine really came into full swing with our management of all these diseases. Somebody would have some chronic condition and it would kill them. So the age, our sort of lifespan was much shorter because of infection would rear up and then you die, or you had an injury and you get a secondary infection from it, or tuberculosis, or any number of things that people would have gotten back in the day. So acute conditions were much more prevalent, but nowadays we manage all these chronic conditions. So these are like long-standing diseases that people have, that are managed. So they're chronic. Think of acute as like it happens fast, it's intense. Like acute pain, it's like, that is acutely painful. Like right now, we're chronic, it's like, oh, it aches, my hip is like always aching. That's chronic. Yeah.
When I work at a rehab center, we would have patients like elderly, they would have a fall or anything that had a hip injury or something, then they would last for a little while and then they would die.
Yeah.
So I think with our patients too, since if they're having hypertension and then they're having the orthostatic hypertension, if they have a fall, it can be really critical to them, and they could actually cause a lot of damage to death.
That's a really, really good point. And that's one of the big things when you're treating your elderly patients is having them get up super slowly. And because of that, like we just don't think about what can happen if they get lightheaded and they might be frail. And we wouldn't want them to break a bone or injure themselves on our watch, right? So yeah, being really aware of setting them up slowly, telling them to sit for a little while. And you'll see more older patients this year than you did last year, I assume, although some of you might have already seen some geriatric patients. And then also going to the senior centers. Have you guys started the rotation at the senior centers? Yeah, those are fun. I like going there to the senior centers. Okay, so oral changes. So I put in, there's some slides that go over this. So this is just sort of summarizing it, but we want to think of how just aging affects the oral mucosa, how it affects periodontal tissue, and periodontal status, or the tongue, salivary gland. What are the drugs? How do the drugs affect these areas? So drug-induced mucosal changes or salivary changes, and then other changes in their mouth. So I just added a ton of stuff just now while you guys were taking your quiz on the changes in the teeth, because I noticed this is the only place on my slide deck, right? Oh, sorry. This is the only place on my slide deck where I have the statement, changes in enamel, cementum, dent, and pulp. And I have a few like summary, but I wanted to give more detail. So in the notes section, I added detail from the textbook so that you can actually see a little bit more fully what's going on. But in general, edentulousness has declined because people have more dental care done. They have implants instead of having a tooth pulled, they'll have a root canal and a crown, and there's just more dental work out there. But what happens is, it used to be that probably, a huge percentage of older people that ended up in a assisted care or a nursing home would have full sets of dentures. And that's not too much for the caregivers to have to like think about. I mean, they are supposed to think about it, and oftentimes they don't do enough, but that's not too much for them to actually have to deal with. But think about somebody who has like bridges and implants and this and that, and then a partial. And so that it's a lot more stuff in the patient's mouth for a CNA or an LPN or a nurse who's not really, they're not an expert in that field for them to manage and deal with. So there's a lot more plaque and calculus buildup around all these intricate dental restorations. So it's great that more people have their natural teeth because they can eat better, they can enjoy their food, and usually their nutrition therefore is better. But it's more complicated to cleanse and take care of. So from the early 1960s, it was 50%, and and this is an old number, so I could be a lot more, but this was from the text, 2002, down to 24% decline in edentulousness. So it's really changed. But we do see changes in the enamel, the cementum, the dentin, and the pulp, and this is just sort of in general aging, and it's going to vary. Somebody who's ground their teeth or had a heavy maybe acidic diet or just genetics have played a part, they're going to have more wear on their teeth, they're going to have more staining, they will have more microfractures. But in general, what we see is everybody gets more fractures in their enamel, and teeth tend to get more translucent and more stained, just because you had a lifetime of drinking wine or coffee or tea or eating lemons or whatever it is that you do, and then your teeth have functioned for 70 years or whatever, and so you get these micro fractures. And so there is this sort of general change in people's teeth where they get kind of a little bit darker, yellower, more transparent enamel, and so the dentin shows through in the staining. Slower production of dentin, but then we also get a shrinkage of the pulp. So in some ways, older people tend to have less sensitive teeth. They might, like when we go to clean their teeth or use the ultrasonic, they might not be as jumpy, which is a nice thing. And that's not, again, everybody, because I've certainly worked on elderly patients who were still like, I'm sensitive, that's my hot spot. But a lot of times, because their pulp chamber shrinks, their teeth aren't as sensitive. So there are some benefits there. And then attrition and abrasion, just from lifetime of wear. And then once you start exposing the dentin, your teeth just wear faster, and then depending on their diet and their habits. But do read through. I don't want to read it all to you because that seems kind of unnecessary, but do go through it, just read those side notes. Those are just important pieces from the book that I think, and they all just relate to those natural changes in the oral cavity. Oh, is it not updated yet? Yeah, it's probably because I didn't save it, but I'll remember or try and remind me, and then I'll just press save and it should update it. Okay, so pathology related. So if somebody has an overall healthy mouth, or an overall healthy state of just overall health, this might be minimal. But one thing that we see a lot in elderly patients is the root caries, and that's because they'll have more recession. They have a lifetime of maybe heavy toothbrushing with maybe a more abrasive toothpaste or a medium or hard toothbrush. Those were very common. You used to be able to go to the store and buy hard, medium, or soft toothbrushes. Does anybody ever see that before? Because that is sort of being phased out. It's pretty hard to find. I mean, I think it's been phased out for years, but you used to be able to pick the level, and then we'd have to tell our patients, always get a soft, always get a soft. Oh, I like the hard, and scrub's good. And so, but then they're wearing away their enamel, and they're wearing away their gingival tissue. So contributing factors to the higher rates of caries, it's most prevalent: recession, salivary quantity and composition. So how much and how good is the saliva in their mouth, inability to complete thorough oral hygiene. There is a lack sometimes of sensitivity and awareness of where they're brushing their teeth. So they might not have the dexterity, and they might just not realize that they're just totally missing an area because they're just not they're just not sensitively aware of it. Previous restored coronal or root decay is going to be more susceptible. Overcompensation of soft, retentive, refined carbohydrates, and frequent snacking. There's all other things too. When we get into the older population in nursing homes, there's pocketing of food where it just can be like just kind of a layer of like crackers or something that's like a fermentable carbohydrate that just kind of ended up in the vestibule up against the teeth and is just hanging out there. And it never got cleansed from the mouth and down the gullet. And so we have to just be aware of those things that are going to increase the likelihood of cavities. Periodontal changes, so age-related in the absence of disease, meaning you have a spry, healthy, vigorous 80-year-old, there's going to be minimal periodontal changes. There's probably some recession, you know, but they can really have minimal periodontal changes if they have been very, very systemically healthy their whole life. Quality of bone, but that being said, there are some changes, and of course, this is going to depend on an individual basis, but quality of bone can be reduced related to metabolism, reduced healing capacities, reduction in gingival nerve and blood vessels. So this, again, is usually triggered more from certain conditions or systemic diseases, but there is some just general aging change that goes along with this, but it's not usually significant if all other things are healthy. Pathology related, if they're dealing with some kind of disease, there's an association, but not necessarily a direct cause from these other conditions between increased age and increased recession. There's attachment loss, prevalence of inflammation, periodontal health in middle age is a predictor for later in life. So if somebody, let's say somebody in their 40s started to experience periodontal disease, bleeding upon probing, bone loss, and maybe it's because they were neglectful, or maybe it's because it just kind of it was hereditary, their parents had it, and so they're just more susceptible and they need to pick up their oral hygiene, come in more often, whatever factors are involved. But then let's say they get it stabilized and then they live 20 years, you know, doing their regular maintenance and they're stable. But if all of a sudden they start losing their ability to have the same level of oral hygiene care, the same level of coming in, then that could rear back up again. Because remember, periodontal disease is kind of one of those things we say it's never really cured, it's just sort of stabilized. And so people, if you have periodontal disease and you have a susceptibility to it, you always have a susceptibility to it. You can't be like, oh, I cured that thing. You have to go back and make sure that you're on top of it because you're susceptible. And maybe it's just because you totally let yourself go and you didn't get a cleaning for 20 years. But, you know, so some people are going to be more aggressive, or their circumstances might make the periodontal disease more severe. But if you have it, you're susceptible, so you have to stay on top of it. So an older person who doesn't have the same ability to take care of it could revisit them in their older age, even if they were stable. Oral changes in the mucosa, again, minimal if in the absence of disease, but if it's related to some kind of pathology or condition, medications or systemic conditions could certainly cause the tissue to be more thin and fragile. The lips appear drawn and there's a loss of elasticity. So we tend to see this kind of like these lines sort of forming, and that can just harbor bacteria and moisture, which can just make it susceptible for, just the bacterial growth or the candida. Angular cheilitis, ill-fitting denture, oral cancer. Average age of diagnosis for oral cancer is 60 years or older, and it's more common in men than women. But we know with the HPV, we have sort of a new generation of risk factors for oral cancer. But it used to be like only men over 60 had oral cancer from smoking and drinking. But now we do have different reasons for oral cancer, but we still have to be aware that they're at a higher risk at that age group. Tongue changes, so decrease in the number and sensitivity of papilla, decreases in sense of smell. So older people like salty, sweet foods because they've lost some taste sensation. So they like salty, sweet foods, and that's not great necessarily for their health. So it's kind of a catch-22. Food is less of an appeal. Nutritional needs may not be met. They're gonna sort of, go for pudding. And, I remember because I used to have a hygiene business. And so my place was, I had a senior center that I set up. And then I also went out to the nursing homes. And I remember I have patients that in their little drawer next to, they would just be filled with like Snickers and, and they would just, be munching all day because they're bored. There's not a lot to do. Nobody comes and visits them very often, if you've worked in those situations. And food is adrenaline, or not adrenaline, epinephrine. Dopamine. What am I trying to say? Endorphins. It makes you happy. It makes you feel good so that's what I was trying to say. So, so that's, people eat food that makes them feel good. Sublingual varicosity. So under the tongue, you see those kind of swollen, large, purpley blue. Yeah.
Our elderly patients, are we just gonna list that in our oral mucosa, or that drop down that says, are there any abnormal appearances?
Yeah, and that's sort of like normal abnormal. Like it's not like you would definitely record it, but it's not like it's something you have to be concerned of. It's like a normal part of aging that you can see. I mean, not everyone will have it, but so yeah, you would just list that.
Well, our scriptures can be what we're seeing right here.
Yeah. Yeah. So deep red or blue black dilated vessels on either side of the midline on the ventral surface of the tongue. Nutritional deficiencies, there's actually a lot of nutritional deficiencies that can show up in the mouth. I mean, that's kind of like a couple slides of its own. So I kind of just sort of minimized it, but anemia, atrophic glossitis, and often the burning mouth sensation or burning sensation, and then smooth, shiny, or denuded tongue. So like a smooth, kind of inflamed, smooth tongue. But there's several like zinc and vitamin C, and then iron deficiency, and there's several things that if patients are deficient in, and this population is the population that you're more likely to see a nutritional deficiency. And then edentulous, the tongue kind of spreads out. Like if somebody doesn't have teeth, and the jaw, the bone is resorbing and everything is sort of minimizing, their tongue sort of seems to get bigger and just kind of spreads out and fills the space. Salivary gland changes, not significantly related to age alone. So that's been through research. Like we kind of think like, oh, somebody ages and their salivary glands dry up. It's not really true. Like if somebody doesn't have these comorbidities or a systemic condition, then they should have roughly good amount of saliva even as they age. Related more to systemic disease, radiation therapy, tumors, medication is a huge one. If present with no medications, evaluate for underlying disease or salivary tumors. So if somebody seems really healthy and isn't on any meds, and their mouth is really dry, there's probably something brewing. I mean, they could just have something specifically going on with their salivary glands, but it wouldn't be typical for somebody to just have that. So there could be some kind of an autoimmune disease or something. But there are some changes that women can experience postmenopausal. 60% older than 50 years old can have an autoimmune condition, the Sjogren's syndrome, and they don't just have the dry mouth, they have the dry eyes and other things that can affect other areas of the body too. So that could be a possibility, or something else that you could just recommend that they talk to their physician about it if they're complaining about it. Remember, if somebody there's hyposalivation, so like there's minimum, like less than desired amount of saliva, and then there's like xerostomia, dry mouth, so somebody could have hyposalivation and it could be affecting their oral cavity, but they're fine. They don't know. They don't really notice. So that's why we kind of check, we milk their saliva ducts to see how prevalent the saliva flow is. And because if somebody has less than desirable amount of saliva, it still can affect their teeth and their mucosa. Oral mucosa, extremely dry, saliva ropey. First, you get that atrophy of the papilla, and later sort of a smooth, lobulated tongue. So you get the kind of bumpy tongue. And the fissures and stuff like that, the cracks and stuff from dry mouth as well. So this is just sort of review on the importance, the purpose, and the purpose of saliva and what can happen if we don't have enough. So we know the purpose of saliva is to lubricate the oral mucosa. We know it helps start the digestive process, and assist in swallowing, assists in speech. If your mouth is really dry, your tongue kind of catches all over the place and it's harder to talk. Facilitates retention of oral appliance. So that's another thing. If they have a removable appliance of any kind, if they don't have the saliva, it's not going to feel as comfortable and be retained as easily. Saliva helps with that suction process. Provides a source of minerals to remineralize the enamel, neutralizes the pH of the mouth. And so if they don't have enough saliva, it's going to affect their taste when they're eating, contribute to plaque formation. They're going to have more buildup, contribute to dental caries, we know, because of all the other reasons. Mucosa can appear dry and inflamed. It can just be sticky and seem like you could almost like rip it sometimes. You can sometimes with I'm trying to think of, definitely with the ultrasonic, I've seen it happen, but that's more of an ultrasonic burn. But some patients can have, like with the suction, if it's a healthier young person, it might just look like an intraoral like hickey or something, like some of their tissue got sucked up into the saliva ejector and it just kind of makes like a little hematoma. But if it's on an elderly person, it can like rip it, and then they might have a little bleeding. So it's more fragile. Their tissue is more fragile. Edentulous persons affect denture retention, comfort, ability to chew and speak. We've just kind of already said that. Yeah.
One of our patients has a salivary duct clogged up, or do we refer them to the doctor, or what do we do in that case? If what are we doing?
I think some people have had sometimes they can break up and they can go away. Other times people, I think, have actually had to have things removed. It depends on if it's really swollen and causing them a lot of pain. And so sometimes it just depends on how big it is and where it is. But some people I do think usually the dentist will either refer them to someone or watch it. It just depends on how bothersome it is and how big it is, because some of them can be pretty uncomfortable. Okay. So then the drug-induced changes, so we think about this with the prescriptions. So a third of prescriptions are for older adults. On average, they take more than 3, and institutionalized patients in nursing homes and assisted living can take up to 5 to 7 to 10 more. I mean, that's average, but they can be on more than that even. And then of course, the most commonly used drugs are going to be the pain medication, analgesics, diuretics for hypertension, oral hypoglycemics, antihypertensive medications of other kinds, antidepressants, and sedatives, all of those causing dry mouth. Yes.
Hard thing about that is a lot of them take their medications with something sweet like applesauce or ice cream or something.
Yes.
If they are filled like 3 different times during the day, that's 3 different ice creams during the day while they're snacking.
Yeah, and who brushes if they don't brush their teeth, who does it?
Honestly,
so then
it doesn't get done until evening time. It's a quick process because there's so many people to get ready for that. So.
The caretakers have always, they get a bad rap because they're their caretakers, but they are usually burdened with so many more people than they can care for. My mom worked in the nursing homes, and then just from me working in there, I saw it too. It's very, very challenging. There's never enough staff, there's never enough funding, but they are the people who own those places. I mean, every patient is like $3,000 to $5,000 a month. And it's like, how can they pay that much money and there's not somebody there who can clean their teeth? That's insane to me. Let's do this slide and then we'll just take a break. Okay, so again, with the drug-induced changes, we know about the medications that can cause gingival enlargement. We want to be really aware of those. Predominantly, those are going to be the phenytoin or the anticonvulsant, calcium channel blockers, that cardiovascular category, and then immunosuppressants, cyclosporin. That's one that we really haven't talked about other than probably briefly in oral med, but cyclosporin is another one that can cause gingival enlargement. And then the xerostomia list is very long, like many drugs cause xerostomia. Okay, so let's take a 5-minute break. Hello. Oh, yes, if you guys can turn in your worksheets, that would be awesome. And I'm gonna go grab the ones off the printer. Hot off the presses. So some other changes that you'll see in the elderly population is you might see a higher incidence of halitosis or bad breath. And that could stem from not just their oral health, it could stem from something in their respiratory tract, or even sometimes like GERD and stomach issues can also play a part in that. But upper respiratory conditions, if they have excessive mucosa or an infection, sometimes that's what you're smelling is infection. Also food pocketing. So that's what I was kind of talking about earlier. It's when they don't have the same sensitivity or like their awareness of where the food is and where their tongue goes. You know, we can feel if something's in our vestibule, and so then like we take our tongue and try to clear it out, or when we brush our teeth or whatever, and we can feel that sensation. But sometimes as people age, especially if they're dealing with any kind of cognitive decline or, you know, any number of things, they might just simply not be aware of the food in their vestibule. Food between cheeks and lips and soft tissue, sort of similar thing. Inability to swallow, loss of sensation, and muscle weakness. So that's the other thing too, is like our cheeks, and when we chew and swallow, like our whole mouth kind of helps us get the food chewed up and swallowed, but they may have weakness in their tongue and their buccal mucosa, like the whole entire facial muscular setup is just weaker, and so it's not going to process as effectively. And also they might purposefully pack food, so they might like a chipmunk, like pack it back there and just leave it there, and that is probably associated more with somebody with cognitive decline. But so just being aware that those things could be present. Yeah. Yes. Just yep. And that's the first, when I went to the nursing home, the first thing I did was took a gauze with like chlorhexidine, or even just like something, I usually try to do something mild, not too like alcoholic, you know, so like not Listerine unless it was like alcohol-free Listerine, but I would wet gauze after gauze and I would just wipe out. I would have like a pile of gauze with, you know, plaque and food and stuff like that. And I promise you, once you've done it enough, it's not as gross. I mean, it sounds horrible, but once you're in people's mouths enough, there's not really that much that grosses you out. I mean, you're going to be used to it at some point more than another. But when I was first out of school, I probably wouldn't have wanted to dive into that. But after I'd practiced for, you know, a long time, and I like elderly people, I like that demographic, it's easy to do. But that is the first thing I would do, just wipe out, and then you try to go to the bigger chunks of calculus, and then but your goal is never to find scale. I mean, they don't have the patience, they don't have the ability to open and stay open. It's like do as much good as you can in the amount of time you're given. And usually that's big debridement. Okay. So for assessment, for your process of care, you want to observe the patient, think of all the different things that we've already discussed, their limitations, their things that they might be more susceptible to, their risk factors. You're going to take in personal, sometimes the mental health aspect or behavioral aspect is a big part of it. So you try to take in all of the pieces for kind of that patient-centered care, that holistic care. So personal, medical, dental history, you do the EOIO and encourage them to do regular, especially if they are able to look inside their own mouth. That's going to be harder if their vision is impaired or if there is some kind of cognitive decline, but within what the capabilities are, you're going to expose radiographs just as normal, even at the senior centers and the nursing homes. A lot of times people are more and more bringing the Nomad and taking x-rays there because it's just becoming more of a common thing for hygienists and dentists to go into these places. And then oral hygiene status, ability to perform, dexterity and vision. So you really want to consider what their capabilities are and what their limitations are with dexterity. And then nutritional status, transportation to get food, ability to prepare healthy food. All of these things there's so many things to think about when caring for somebody that's older, especially if there's lots of comorbidities. Describe your typical diet, like they live alone and they're not cooking for anybody. Nobody cooks for them. They're probably eating a lot of simple to prepare food. They might be eating quick carbohydrates and things like that. So you try and assess their dietary needs and what they're getting. Modifications, accessibility of the dental office, the parking lot, ramps, doorways. Is there tripping hazards? Is the lighting going is the door heavy? Does it stick? And so most people can get in just fine, but you have your elderly patients that are going to be wrestling with the door, has the office considered all these things? Are there handrails in the restroom? And that's not your job per se. It's, but when you're aware of those things, if you go work for a dentist that's kind of oblivious, you can help make those improvements. If it's a place like Kaiser or Willamette, likely they've covered all those things because they're dealing with a much bigger corporation. They have to, but also thinking about the patient's stress level, fatigue, they fatigue easily, they get tired easily. So usually as like with many patients, morning appointments, they're going to have more energy, but not early morning, not like 8 o'clock. These are going to be your patients that love the 10 or 11 o'clock slot. So they're not going to want to be there like bright and early because they got to maybe figure out a ride and things like that. But they're going to be good for that time slot, maybe not so much right after lunch when they might want to take a nap. But shorter appointments, their TMJ and just holding their mouth open could be harder. They might shake from fatigue. So limiting long appointments for sure. And then thinking about transportation time. It could take, if they have to go, if they're coming from an assisted living, there might be a bus that schedule. So they have to put all those things into consideration. Assistance with walking, do they use a walker or cane? And so help them get into your operatory, help them sit, and then put their cane or their walker somewhere where they see it and it's like accessible, but you'll help them get back out of the chair and kind of raising the chair to the appropriate level. If your chair is low, raise it up for them so that they're just going a shorter distance. You don't want them to like flop down into a really low chair. So thinking of all those courtesy things, but also really important for just helping them navigate the room. Dental chair, so I already said that. Armchair, is the armchair out of the way? Some dental chairs are designed so horribly. I've worked for places where you couldn't get the armchair out of the way. And so they'd have to like go around. I mean, I'd be like, or it would move back like 3 inches and that was it, and the nice ones are when they're like totally can get out of the way. And usually in this class, historically, I've always done the special needs unit first. And so we talked about wheelchair transfer and adapting different oral hygiene tools. But because I wanted to start with cardiovascular and diabetes, because we had changes in our clinic manual, so I changed everything around. In this year, we're talking about those first, whereas usually we don't. But we will talk about some of these impairments that can happen just in the general population: wheelchair, somebody who's in a wheelchair, blind or deaf, or just limited vision or hearing. So we do kind of revisit this, and a lot of those things overlap with the age elderly population. You want to think about if there's hearing or vision impairment, you want to think about assistance with forms, large print, maybe magnifying glass, good lighting so that they can see, maybe have it printed in, make sure that the font is dark and very contrasting so that they can see it. When you're interviewing somebody, it's kind of typical to like raise your voice and go into a higher pitch, but you want to actually try to stay like lower pitched when you're talking, because it actually helps them hear better. And then of course, if you're behind a face mask during COVID, it was the worst because we could never remove our face masks and it was awful. They had designed some that were clear so that you could see lips moving, but you do want to take down your mask and talk to your patient so that they can see your mouth moving. It helps a lot, especially if they have a hearing impairment. Shouting is unnecessary and ineffective. So it's like with anybody, whether it's somebody that's like hearing impaired, you know, you want to make sure that they are understanding, but just sitting there yelling I kind of feel like that's what I'm doing right now, is just yelling. Like, am I yelling? But you don't want to just raise your voice and talk loud. It just can be insulting and come across strange, but you do at the same time want to make sure that they can hear you. Eliminate background noise is a big one. If there's like hissing from other high-speed handpieces or high-speed suction, the dental environment is very noisy, and music playing, people talking, I mean, it's very noisy. So you do want to try and minimize that when especially when you're have a patient that has some of these limitations. You want to try and see if you can minimize that as much as possible. If there's a caregiver, continue to speak directly to your patient and then check with the caregiver at the end, because they might, you might say, well, you might want to just take a few notes, but respectfully speak to your patient, even if you know it's the caregiver that needs to know this stuff. And it's just a courteous thing. It's just a way to provide dignity to your patient. You don't talk about them like they're there, but blah, blah, blah. It's just a nice way to like preserve dignity in your patient. And then we always want to think of informed consent. Dental hygiene process of care. So these patients are typically going to be more complex. To sort of summarize what we've already talked about: chronic conditions, more complex periodontal dental conditions. Evaluate their need for pre-med. They might be at this group might have a higher rate of needing pre-med. Functional versus chronological age. Don't assume just because they're 60 that they're healthy and cognitively all there. Dexterity, they may have more limitations than somebody who's 85 just because of their various circumstances. Human needs differences. Everybody is going to have a different need. It could be stress and fatigue, or it could be, a specific disease that they're dealing with, or financial burden, transportation. There's lots of different scenarios. And then perception of needed oral health care. So are they actually getting access to the health care that they need? And what can we do to help them in those situations? Reduction in health or healing capabilities, as little trauma as possible. So just being really, really purposeful with your instrumentation, be very aware of the suction, just knowing that you just don't want to be heavy-handed with this, pulling of their lips, they might crack and bleed a little bit more easily. Tissue just might be more frail and thin. So just being more gentle and aware with this population. I mean, you want to be that way with everyone. You don't want to cause undue trauma to anybody, but this population can be a little bit more fragile in that respect, especially if they have multiple conditions. Oral retraction can be uncomfortable. Specific OHI to ensure necessary knowledge and skill. So tailor your OHI for their abilities and their needs. At the end of the appointment, make sure you raise your patient up slowly to the upright position. You don't, your chair may go at just like, but just you could go like up and then wait a second and then up and then wait a second and then up. And I usually tell my patient that's what I'm doing. I want you to sit here for a second. I don't want you to jump right out of the chair now. None of them are going to jump out of the chair, but you can say it to like, let them know that's what you're doing. Say, I'm just going to raise you really slowly and then, give it a little bit of a break. And then once they are fully up, then make them wait a minute. Usually they do naturally anyways, but some like to move because they might not have liked laying down. Maybe they don't think that they're going to be dizzy. Allow them to sit upright for a short time, assess the needs for assistant, post-operative oral hygiene instructions written and reviewed. So things, you have to say stuff multiple times, and usually it's good to have it written out, especially if they pretended to hear you, but they didn't actually hear you. So you definitely want to make sure you have stuff written and reviewed for them. Frequent perio maintenance appointments, oftentimes it's better for them to come in maybe every 4 months or every 5 months, but and certainly every 3 months if that's their perio status. But a lot of times they may not want to, or financially they can't. So, you just do what you can or what the patient can. Evaluate carefully physiological chronic conditions, pathological changes, note changes. And then the health status can change very quickly. They could be diagnosed with cancer or a Parkinson's disease or have a heart attack. I mean, they can be healthy one day and then 6 months later, what happened? And then they'll tell you the whole story of what happened, so health things can change very quickly in this population. I mean, that's true for anybody, but especially with the elderly population. Evaluate functional abilities to complete oral hygiene, nutritional changes. A lot of this is repetitive. Oral care with cognitive disorders. So I won't read through all of this, but if somebody has cognitive decline, they're either going to not want you to touch them and be combative. They don't remember how to brush. They don't like the feeling. They don't either remember to do it. Like maybe they would like to do it, but they just don't ever remember to do it. So there's so many variabilities to it. So you just have to be aware of all of those things. Medication changes, early morning appointments. This is sort of just summarizing. So you should read through these on your own, but I'm feeling short of time, so I don't want to spend too much time on each slide. Speaking slowly, clearly, short sentences. If there is some kind of cognitive decline, the tell, show, do, and limit their choices. Don't give them a whole bunch of stuff. Give them like one thing and get them to do that one thing or maybe two if it's just mild cognitive decline. If there's a caregiver, you can talk to them about ways to like prop them up and do some oral care. So here's some recommendations. Of course, telling them to remove the appliance, physically supporting or aiding in their daily oral care, visually inspect the quality of their oral care, could show them how to retract the cheeks, how to look in the mouth and what to look for, and encourage the patient during and after care, and then provide written instructions for the caregiver. So give them some simple instructions and tips and a lot of times, you can say, put them back in a recliner and then stand behind them and pull back their cheeks. And that's better than doing this, and like trying to squat down facing the patient and come back from behind. So give them some tips. They would never think of those things because they're not hygienists. So, and then you can write those things down. Modifying oral hygiene, it's anything that has a fatter handle, electronic toothbrush with a bigger handle, making handles bigger by putting it, cutting a hole in a tennis ball and sticking it in a tennis ball or wrapping a washcloth around it so the grip is bigger. So there's so many things that you can do to help modify, but you want to think about those things. Can the patient utilize those things? How's their dexterity and their vision? Recommending different rinses or lubricants if they have dry mouth, swabbing, having a caregiver just swab out the mouth with, like a wetted gauze or even a washcloth and just rubbing out the mouth in general, just to get rid of debris. Powered flossers, and then it's nice for you guys, we have the Vaseline, you can lubricate the mouth, and they can tell the caregiver to do the same thing, because they might have dry mouth on the outside too. Management of xerostomia and caries. This is just read through this. This talks about fluoride, xylitol, toothbrush with a modified handle, just saliva replacement, nutritional counseling. So read through that slide, but that's kind of some review stuff. Sorry, I'm getting phlegmy. You'll get more of this. I'm totally like froggy all of a sudden. You'll get more of this stuff in Wilbur's class. So it's not really, I'm not going to really go into it, but there's a whole heap of information to learn about mobile dentistry, the advantages of on-site dental programs, people that go to these sites as opposed to the patient coming to you in a dental office. So there's all sorts of wonderful information there. So read through those. Patients are dealing with barriers to care, insufficient number of dental health providers who actually will go to those areas. I'm like, yes. Welcome. Poor attitude of dental professionals, low financial return. Those are some of the reasons why it doesn't happen very often. Not everybody thinks going into a nursing home sounds fun. Like a lot of people might be like, ugh. But that's why we love that you guys are on these rotations, because you actually, a certain amount of you, not everyone, it's not expected that everyone will, but there will be some of you that love it. And your heart is there. That's where your heart is. And so, but it's not everybody's thing. And it is true that it can have a low financial return, but I will tell you, there are hygienists all across the US who make good livings doing independent dental hygiene care to patients that can't get out. Any kind of special needs or assisted living, nursing home. And you just have to be smart about your business plan. And it depends on the state too. But I mean, if you really are interested in that line of work, it can be really rewarding and financially rewarding too. There is changes all the time in legislation and reimbursements. And so in general, this is what keeps people from it, is, going to work for a dentist and getting a paycheck, is, and benefits. That suits a lot of people much better, but there are avenues within independent practice. Not covered under Medicare, federal benefits. These things are changing. I mean, this slide, I should probably do a little more deeper dive, because it does vary by state, but all of this stuff is changing. Benefits for the federal government, they're expanding dental benefits all the time. And hygienists are seen as primary care more and more often. So your role as a dental hygienist, provide clinical care, provide in-service education programs for staff and or family members. You can go to these places and you can charge for an in-service for an education, or some people do it for free to have that be their in to some of these facilities. And that's sort of their buy-in, is I'll give you free CE, and I'll be the hygienist that comes here and gets the clients. There's all different ways of doing things. Refer if they detect unusual signs or verbal complaints. So this is again, you going to the place, not so much them coming to you. There's things called brief oral health status examinations. It's something that every single person coming into a nursing home has to have. So they need usually a nurse does it, but a dental hygienist is far more qualified. Dentures should always be marked with permanent identification. Fluoride application is necessary for everybody in the nursing home. Developing individual care plans is super important. Everyone's going to be different. Modifying oral hygiene aids these are all huge resources that makes you a resource for these places. on top of cleanings and everything else. Yeah.
So the brief oral health status examination, is that like pretty much the screening? That we
Yeah,
do?
every single new patient that comes into a nursing home has to have a screening, and they have to have somebody say what's going on if there is. And a lot of times it's not thorough enough because a nurse looks at in there and says like, are you in pain? And if they're kind of like, nope, then they're like, good. But they might not see something that actually like, well, this person needs cleaning, or this person has a tooth that's abscessed that you don't even know because you're not an expert in this area. So they usually do these, or they say, oh, they have dentures, or no, they don't have dentures, but they're not nearly as thorough as they should be. Some might be. I mean, I don't want to throw the baby out with the
So
bathwater.
this is something that like we're gonna go into like the nursing home, so then we come through, cause like we had rotating procedures in our last week,
Mhm.
and we were doing our own screening.
Yeah.
So those ones are not in depth as what we do as
Oh,
university.
yeah, yeah. What field work requires of you, it's probably far more thorough than anything that the nursing homes do when they intake a new patient. When they intake a new patient, they just do some standardized oral peek. And some places might be better than others, you know, like I said, I don't want to just say they're all not, but in general, they're usually not marking things like this patient needs a cleaning or this person has, you know, whatever. They're looking for really big, obvious things that they want to get done before the patient settles into the nursing home.
So there's no like stipulation standard of like care when it comes to like that type of evaluation across the board.
It's pretty standardized, whatever it is, whatever they do. And I can't remember exactly like there, but I guarantee you what you guys do is more in depth for sure than what they do. Because it's brief, after all, it's a brief oral health status. Okay, so quickly just jumping into palliative care. This is for a patient who is generally speaking like on hospice or something. So this is somebody who is usually close to death or is critically ill, like they have advanced cancer or something like that. So palliative care, any form of care that focuses on decreasing disease symptom severity for individuals with life-limiting illness. So the purpose of palliative care is not curative. It's not even necessarily to like reverse disease. It's for the patient to be comfortable. And so do we want to reduce the severity of the discomfort? It's mostly for patient comfort, so that as they die comfortably. Like that's the main purpose of it. So care does not involve delaying or reversing disease progression. Palliative oral care management and prevention, or oral problems caused by disease or a treatment of disease. Wait a minute, what did I just say? Palliative oral care. Oh, that's the definition. Like, what am I saying here? So that's the definition: management and prevention or oral problems caused by disease and treatment of disease. But again, we're trying to prevent things from getting worse. We want to manage what's there, and we want to prevent something from getting worse because we want our patient to be comfortable. So focus on patients' immediate quality of life, things like keeping tissue moist, reducing the discomfort and the severity of mucositis, you know, all of these kind of intense acute things that might increase discomfort at that time. So the goals, kind of repetitive, I probably already said it: provide relief from symptoms, especially pain. So trying to keep the patient pain-free and comfortable, support holistic patient care and enhance quality of life. A patient who is on hospice and is still like awake and cognitive, and this is true for nursing home patients, if you get in there and clean, like give a thorough toothbrushing, even if you haven't removed all the calculus, I mean, it can make some of them almost tear up. It feels so good to have, if you haven't had your teeth brushed in a month, and to have somebody come in and brush your teeth really well, it can be the most like, it can feel so, so good. So if you think about somebody who's on their, like dying and just laying there, like, like you haven't had a nice shower, your mouth feels scuzzy and fuzzy, to the 10th degree, your mouth is dry. So this stuff can just be like the difference between night and day to somebody who's just little things mean so, so much. And so that's true for someone not even in hospice, but definitely these are the main points for someone who is in palliative care. Offer support to patients to live as actively as possible until death. So we want to address all of that stuff, because hospice might mean like in bed, sort of barely conscious, or it might mean like they're still, taking on fluids, taking a little food, but they just know that they're in, terminal, Affirm life and neither hasten nor postpone death. So it's just sort of accepting the process of what's coming and keeping the patient as comfortable as possible. But never always affirming life, like as long as they're alive, and so we treat them, with the care that they deserve. And then regard dying as normal process. People who work in hospice are always like amazing individuals. Offer support to family during the patient's illness and in their own bereavement. Family members love that there are people that want to care for somebody fully and thoroughly, even on their deathbed. Like the fact that they don't just kind of like, well, they're dying, and like the fact that they are tending to their family members, it means a huge amount to people. So standard palliative oral hygiene care, mouth determined to be overall healthy. If the mouth is determined to be overall healthy, brush all the teeth, clean the tongue twice daily, lubricate the lips, keep their tissues moist. Take ability to swallow and spit into consideration. So we wouldn't necessarily want to bog them down with lots of foamy pastes or rinses. So things that are viscous and would cover and keep things moist, like gels, like thin layer of gels would be better. Include the denture care, taking out the denture, cleaning it, lubricating the oral cavity and putting it back in if that's appropriate. Utilize a mouth rinse if possible, but again, you don't want them choking on liquid, so you have to be cognizant of if that's appropriate or not. Palliative care for intubated patients, oftentimes a suctioning toothbrush is utilized. It sucks, there's like a toothbrush on a suction, and it's like a vacuum, and you go in there and you brush and it just sucks up. And those are actually really nice to have, even if someone's not on palliative care. And then disposable mouth prop, you might need to prop their mouth open because you might not be able to get in there otherwise. And that's true for people, again, that aren't in hospice. Some of the complications are mucositis and ulcerations, just very fragile tissue, and just all around inflamed oral cavity, mucositis. And then common with cancer patients who have had radiation therapy. Chemotherapy reduces the mitosis, the cell division. And so that's why you get this inflammation and these cell problems in the oral mucosa. Because usually our mouth, we turn over and slough off the cells quickly, and it reduces it when they're on chemotherapy. That's why the mouth heals. Typically we say, oh, the mouth heals so fast, in like a few days that'll be healed up because our cells turn over so fast. Keeping patients' mouth clean and moisturized is key to reducing and preventing mucositis. And this is good info for just a patient that you have that is about to start chemotherapy, but we'll talk about that in that unit. Rinse with chlorhexidine if possible, or just sponge it out. Topical corticosteroids may be used to also reduce inflammation. Oral candidiasis, they're going to be a higher risk for that. Most common fungal infections occur in patients who are in palliative care because their immune system is just shot, and all sorts of other things. Imbalance in the oral flora. It can be treated systemically or topically. Candida can lead, levels can be higher if someone's wearing a denture. So that's good info to pull over to your the prosthesis lecture. Xerostomia, and we should be familiar with xerostomia by now. Talk about it with everybody and everything. Mucositis and alterations. There's something called magic mouthwash. It's often prescribed by oncologists. It varies with its ingredients, but it usually has antihistamine, antifungal, topical analgesics, and antibiotics. It's like a mix of stuff. And it can also be coating, like there can be like milk of magnesia in it. That was my bell to stop. Baking soda, saline solution to decrease the acidity of the oral environment, topical lidocaine, and then some of these other Maalox, this is just another kind of a rinse that they combine with Maalox, and it's kind of coating. So let's see. That's the process of care. That just kind of summarizes what you might do with a patient if you go into a nursing home, interview patient and caregiver, perform the oral health screening, figure out what's going on. You're going to do your dental hygiene diagnosis, planning the palliative care. What do you need to do? Consult with the care team. There's a whole group of people in the palliative care team. So you want to consult with them. And then you implement your care and evaluate your care. So what do we have, like 5 minutes, 10 minutes? We'll do 10 minutes. So let's work on this for a few minutes. This is your case for an older, take one and pass it along. That's your case for an older individual, an elderly patient. So you guys can work together on that.